Thank you very much, Dr. Marwan, and thank you for the organizing committee. Thank you for SSBMT and Dr. Lasker, and thank you for Astilla to giving me this chance to present for you. This is the last lecture, so I hope will not take time. We'll have short presentation, then I'll have two cases from our experience at King Faisal to share with you. This is our disclaimer. Okay, so we all know that AML is a heterogeneous disease and multiple mutations. As you can see here, the common mutations in AML and FLT3 ITD is represent around 30% of mutated AML. And we all know that the FLT3 mutated mutation significantly and negatively impact the prognosis in AML, mainly because of short duration and increased relapse, and this translates to shorter duration of survival. As you can see on this Kaplan-Meier for FLT3 mutated AML in frontline. So the compared FLT3 ITD mutation compared to wild type, they have shorter duration. It's translated to shorter overall survival. It's not only on the frontline and also in relapsed refractory. It is significantly and dismal outcome for FLT3 mutated AML in relapsed refractory setting. As you can see in this two cohort, the CRP is around only 20%, and the overall survival ranging from 3 months to 6 months. So dismal outcome for FLT3 mutated AML in relapsed refractory setting. Things is changing, and we hope will change more with multiple FLT3 inhibitor that we have. It's still in pipeline. We have a couple of FLT3 inhibitors in different stages of clinical trials. And you all aware about the landmark trials. We have the Ratify trials, which led for the approval of midostaurin. So midostaurin in combination with 3+7 had significant survival compared to placebo with 3+7, and this led to approval in midostaurin in frontline FLT3 mutated AML. The other landmark trials for is the Admiral, which led for approval of gilteritinib. As you all know, gilteritinib as single agent was compared to salvage therapy, which include intensive and low-intensity chemotherapy in relapsed refractory setting, and there was significant survival benefit for gilteritinib. There was other clinical trials for other FLT3 inhibitors. You can see on the right upper corner the Quantum trial for quizartinib. It also showed a significant survival benefit for quizartinib compared to intensive and low-intensive chemotherapy in the relapsed refractory setting. Did not get FDA approval for multiple reasons, censoring and others. But still, with this FLT3 inhibitors, we did not change our practice. All FLT3 inhibitor, with minor exception, will proceed for stem cell transplant. And you can see here from ALN guideline that they recommend transplant for any AML with expected relapse, 30 to 40%, or more than 30 to 40%, which is applicable to FLT3 mutated AML. And we should proceed as soon as we have CR. This is in first line and also in CR2. Definitely, if you can proceed for transplant, you will proceed for transplant. But the question that we usually ask ourselves is, we know that transplant is better than no transplant in FLT3 inhibitor, in FLT3 mutated AML. But if FLT3 mutated AML proceeded for transplant, will transplant affect the outcome? Will transplant mitigate the effect of FLT3 mutation in AML? As you can see on this registry data, around 700 or more than 700 patients from EBMT, acute leukemia working party, when they stratified the patient according to the molecular mutation, you can see that FLT3 mutated AML did worse than FLT3 wild type AML in leukemia-free survival and overall survival. For sure, the NPM1 mutated AML will do better. But still, even with transplant, the FLT3 mutated AML still they do bad compared to other AML. Here, another older EBMT registry, around 200 patients when they stratified FLT3. This is post-transplant in CR1. So when they stratified the patient to FLT3 mutated versus FLT3 wild type, again, FLT3 mutated AML had increase the cumulative incidence of relapse and decrease relapse-free survival when FLT3 mutated AML compared to wild type. So that gives us an indication that we need continuous inhibition for FLT3. It's not enough to send them for transplant. And you can see here, this is the recent statement from EBMT when they discuss the transplant in FLT3 ITD mutated AML. As we all agree that all FLT3 mutated AML should proceed for transplant. Controversial exception if you have FLT3 low allelic ratio with NPM1 mutation, especially if you're careful with the MRD and the MRD negative, those patients you can avoid transplant, but other FLT3 mutated AML, we have to proceed for transplant. Very interesting statement from EBMT about post-transplant maintenance. As you can see here, there are unmet need for approval for maintenance therapy for patients who are undergoing allogenic stem cell transplant. We know that there is some clinical trial about sorafenib with SORAMIN trials with improvement in relapse-free survival, but still it's not the standard of care. All of us in our practice, we use sorafenib, but we need better and tolerable FLT3 inhibitors post-transplant. There is multiple clinical trial now ongoing examining the FLT3 inhibitors post-transplant. Let's try to examine our current data. We can just look quickly for Admiral trial, and I think Dr. Ayman was discussed already on the afternoon about the Admiral trial. I will concentrate mainly on patients who underwent transplant in Admiral trial. So briefly, you all discussed today with Dr. Ayman the Admiral trial in the afternoon. It was the gilteritinib versus salvage therapy in relapsed refractory. Gilteritinib was single agent. And the patient in both groups was allowed to proceed for hematopoietic stem cell transplant. In gilteritinib group, patient was allowed to resume gilteritinib after transplant. And there was no crossover for gilteritinib on the control group. So this is the main endpoint or primary endpoint. There was overall survival benefit with gilteritinib compared to salvage therapy, as we all know. Here is unplanned analysis. It's a post hoc analysis. We all knew that there was more patient on gilteritinib group underwent transplant compared to salvage group. And this was one of the criticism for Admiral trial, that more patient transplanted on the Admiral trial. But although with this more patient on the gilteritinib group, when they censored patient at transplant, there was still survival benefit in the gilteritinib group compared to salvage group. As you can see here, 8.3 months compared to 5.3 months when they censored patient at transplant. Another point that we want to examine on the Admiral trial, as we mentioned, the group with gilteritinib, there was allowed to resume gilteritinib after transplant. Not all of them, as you can see here, gilteritinib was 63 patients underwent transplant in gilteritinib group compared to 19 patients on the salvage chemotherapy group. 60% of patients in the gilteritinib group resumed gilteritinib post-transplant. So it's very interesting to see what's the difference in the outcome between gilteritinib patient who resumed gilteritinib versus patient who did not resume gilteritinib. But keep in mind that this is post hoc analysis, this is unplanned analysis. There may be a selection bias for patients who were able to continue and resume gilteritinib, but it's very interesting to see what's the difference between the two groups. So again, this is a post hoc analysis, but as you can see here, the overall survival was significantly better for patients who resumed gilteritinib, or we can see that continued maintenance gilteritinib after transplant compared to patients who did not resume gilteritinib. And you can see in the box below the criteria when patient will resume gilteritinib. So the protocol allowed gilteritinib to be resumed after hematopoietic stem cell transplant in the following condition: 30 to 60 days post-transplant, successful engraftment shown with ANC and platelet recovery, and no grade 2 or more graft versus host disease, and patient in CRC. So those patients were able to proceed for gilteritinib maintenance, and those patients did better than patients who did not receive gilteritinib maintenance. So in conclusion, we know, or we all agree, that FLT3 ITD mutation associated with poor outcome with AML. And FLT3 ITD mutation adversely affect the outcome of hematopoietic stem cell transplant, as we discussed. And maintenance therapy is utmost importance and unmet need in this situation. In the Admiral trial, FLT3 mutation or mutated AML, as we discussed, more patients in the gilteritinib arm were able to undergo a transplant, and when we censored those patients, the survival was better with gilteritinib group. And post-hoc analysis showed the median survival was longer in patient resumed gilteritinib post-transplant versus patient who did not resume gilteritinib. So I will proceed now with two cases from our experience at King Faisal. So those are the last two patients that we give them targeted therapy for gilteritinib. So the first patient, she is a 24-year-old female, previously healthy, presented with headache, anorexia, weight loss, and gum bleeding, found to have cytopenias and circulating blast. This is her basic line, basic lab, circulating blast 68%. Bone marrow aspiration, biopsy confirmed AML with monocytic differentiation. Blast was 70%, flow was classic for AML, diploid karyotype with negative FISH. NGS, in-house NGS showed mutated IDH1, NRAS, and RUNX1. And this is the result for the NGS. So our final diagnosis was adverse risk AML with mutated RUNX1. We examined the family for any possibility of familial RUNX1. It came negative. So we used our standard induction therapy with 3+7. Day 28 bone marrow was persistent disease or almost 10% blast. Reinduction with our standard salvage therapy, FA, fludarabine, RC. She achieved CR at that time. So we proceeded directly for allogenic stem cell transplant with match unrelated. Day 0 was in December 2020. We used BU, flu, ATG, our standard MUD protocol conditioning regimen. She did well post-transplant. Her day 60 chimerism was almost complete, myeloid 100 and lymphoid 97%. Unfortunately, around day 100 post-transplant, she relapsed. And the repeated molecular profile at relapse with NGS showed a new FLT3 ITD mutation, which was not there before. And the variant allelic frequency was 27%. She also had TP53 mutation with small VAF 5.6. The IDH and RUNX1 persist from the initial diagnosis. Since she had a new FLT3 ITD mutation and 3 months post-transplant, she is not fit for intensive chemo. So we give her a hypomethylating agent with first-generation FLT3 inhibitor with sorafenib. She was able to receive 2 cycles, but she did not tolerate it very well, to be honest. She had a lot of skin rash, multiple admission with febrile neutropenia, so we interrupted the sorafenib for a couple of times. We requested for her gilteritinib. Gilteritinib arrived on July 2021. We started her directly on gilteritinib as single agent. She continued the first month, 28 days, but she was having continuously circulating blast. So at this stage, we were discussing between us, like she had FLT3, she had TP53, she had IDH. So what's the point of continuing only gilteritinib, targeting only FLT3? So at this stage, we continued gilteritinib, but we add another therapy. We added venetoclax and we added Vidaza, so we continued as triplet therapy. Unfortunately, she did not tolerate. We were able to give her 2 cycles, but she continued to be active disease, and Allah rahmah, she passed away. So the second case, this was 22 years old female diagnosed in December 2018 she presented with syncopal attack. She was diagnosed outside the country. So the initial treatment was outside the country, and later she referred to us in King Faisal. So diagnosis 2018, pancytopenia, bone marrow confirmed AML, 59% blast, Cytogenetic was translocation 69, so high-risk disease, and she had FLT3 ITD positive from the initial diagnosis. So she received the standard induction with FLT3 mutated AML with 3+7 plus midostaurin. She achieved CR. She received 1 cycle of IDAC while waiting for transplant. Unfortunately, disease relapsed early before transplant. She received salvage chemo with, again, midostaurin. She achieved CR2 with normal cytogenetic and negative FLT3 ITD. She underwent haplo stem cell transplant from her mother in October 2019, complicated by gut and hepatic GVHD. She received post-BMT maintenance therapy with sorafenib. Unfortunately, her disease relapsed back in August 2020 after the haplotransplant. This is her second relapse. So back in her country, she received gilteritinib-based therapy, gilteritinib plus VIN plus AZA, and referred to us at King Faisal for possible second haplo. So when she arrived to us in King Faisal, she was a bit cytopenic. We did for her bone marrow, and that bone marrow was after like 4 cycles of triplet with gilteritinib. It was hypocellular, no blast, so MLFS, but cytogenetics was positive for 6/9, and molecular was positive for FLT3 ITD. So we continued her on gilteritinib as single agent. After long discussion, we decided to proceed for second haplotransplant from her father. We changed the conditioning with TBI-based. We took the chance since bone marrow was hypocellular. So she underwent transplant with TBI-based therapy with still persistent cytogenetic and molecular positivity. Day 30 bone marrow showed CR with normal cytogenetic and FLT3 ITD negative. Started on gilteritinib after almost on day +40 from transplant. She's now almost passing 1 year post-transplant, and she's still in remission and still on gilteritinib maintenance. So conclusion from 2 cases, both patients had adverse risk feature other than FLT3 ITD. So difficult to decide to use single agent FLT3 alone when you have other major or other driver mutations. Very important lesson to evaluate a patient on relapse, because FLT3 and other mutation can emerge or can evolve on transplant setting, relapse setting. Patient with early post-transplant, especially our first patient, she relapsed early. We don't have potent FLT3 inhibitor gilteritinib at that time. We started her on non-selective FLT3 inhibitor. She could not tolerate. So maybe if you have a potent selective FLT3 inhibitor early and you start early, you might have a better response. And here I conclude. Thank you very much.